Hello. Good afternoon, everyone. On behalf of Department of Rognidan, Evam, Vikriti, Vigyan, I warmly welcome all the respected dignitaries, Honorable Dean Ma'am, Dr. Podar Ma'am, respected Head of Department and Professor Dr. Santosh Virbide Sir, Organizing Secretary and Associate Professor Dr. Jyoti McDumber Ma'am, Joint Organizing Secretary and Assistant Professor Dr. Sandeep Kare Sir, our invited speakers, and all dear postgraduate students. I hope we are audible and visible to everyone. I kindly request you to confirm the chat box once. Okay. Before starting the session, let us seek blessings from Lord Dhanvantri. Before the commencement of our program, I request you all to join us in Dhanvantri Savan.
नमामि धन्वन्तरिमादिदेवम् सुरासुरैर्वन्दितपादपद्मम् लोकैर्जरारुक्भयमृत्युनाशम् धातारमीशं विविधौषधीनाम् शङ्खं चक्रं जलौका दधदमृतघटम् चारुतुभिश्चतुर्भिः सूक्ष्मस्वच्छादिहृद्या शुकपरिविलसन् मौलिमम्भोजनेत्रम्
Thank you all. Now I request our Dean, now I request Dr. Renuka ma'am to kindly introduce our dignitaries. Thank you.
Good afternoon, everyone. I request our organizing secretary and concept developer, Dr. Jyoti Megdambar ma'am, to put forth aims and objectives of our webinar.
Thank you, Dr. Renuka. First of all, I would like to thank our respected Honorable Dean, Dr. Sampada Sandeep Sant Madam, who has given us this opportunity to conduct this webinar series from Department of Rognidan. Secondly, I would like to thank our respected head of the department and professor, Dr. Santosh Girbide sir, for this opportunity and taking initiative for conducting these webinars. And all my colleagues, my PG student, I'm very much thankful to all of you. Now, just without wasting much time, I would like to share one thought only, like how this concept developed. Before 2 months, when we are preparing for the modular assessment, question papers for third semester assessment and the modular assessment, at that time we realized that we cannot write the question papers in details, because there are so many unhidden sections which we cannot teach our students. For example, radiology, we are not expert in that because we have done our MD in Rognidan and Vikriti Vigyan, right? So dear students, we have discussed with our HOD, respected Sir Girbide sir, and I shared him a thought, ki sir, can we conduct this webinar series by calling expert members, because I'm not radiologist, you are not radiologist, I'm not pathologist. Here nobody is actually acquainted with many of the fields, I think. So that sir said ki yes madam, we can go ahead. Then we sent our proposal to respected Dean madam, and Dean madam always very, very positive for conducting so many positive things in Podar College and Hospital. So by this way, this concept developed, and right now this conducting webinar series, this is a very good opportunity to dear students. Please take initiative, be attentive, be productive, be creative, and be enthusiastic, energetic, and happiest for learning this webinar. And so many experts are there that we cannot call them offline to conduct the lecture. हम बार बार नहीं बुला सकते experts को, right? So that this is very good session, and we are going to conduct this according to the NCISM norms, according to the notional learning hours. So you can maintain the documents regarding that, because this is very, very essential for quality control, I mean QCI, for NCISM, as well as for LIC, that is MUHS inspections. So my request to all the faculties who are HOD and professors over here, I request you ki please maintain the documents according to this webinar series, and so that you cannot, if you cannot conduct these topics, there is no problem. You can take only Ayurvedic subjects in your respected colleges. So thank you very much. Thank you very much, Dean Madam, once again, and thank you very much, respected HOD sir, Dr. Santosh Girbide sir. Thank you.
Thank you, Dr. Jyoti ma'am. Now I request our chairman and head of our department, Dr. Santosh Girbide sir, for his commencement address for this session.
Good afternoon, everybody. On the behalf of Department of Rognidan Vikriti Vigyan, I extend a warm welcome to everyone present for today's session of Rognidan PG Academic Forum 26. The object of this webinar series is to help our postgraduate students to develop clear diagnostic understandings by integrating classical Ayurvedic concepts with modern investigative methods. Through this platform, we aim to make syllabus more concept-oriented, clinically applicable, and easier to comprehend. I sincerely thank our respected speakers for kindly accepting our invitation and sharing valuable knowledge with our students. I also appreciate the effort of our organizing team and postgraduate scholars who have worked day and night to make this session possible. I request all participants to actively listen, interact, and make the best use of this academic opportunity. I also thank our Dean, Dr. Sampada Sant Madam, who give permissions to this activity, and our team leader, that is organizing secretary Megdambar Madam, and our departmental faculties and all PG students have given mostly inputs to succeed this webinar. Thank you.
Thank you, Dr. Santosh, sir. Now I request our Dean, Dr. Sampada Sant Ma'am, to kindly grace this session with their inaugural address.
Respected resource person, faculty members, dear postgraduate scholars, and all the participants joining us online, a very good afternoon to everyone. It gives me immense pleasure to welcome you all to the Ayrn PG Academic Forum 2026, organized by the Department of Rognidan. In recent years, the postgraduate curriculum has become more structured, integrated, and clinically oriented. While this is a positive step, it also demands deeper conceptual clarity and a strong understanding of modern diagnostic sciences, along with the Ayurvedic fundamentals. I appreciate the sincere efforts of the organizing team, faculty coordinators, and the postgraduate students who have taken initiative to create this academic platform. I also extend my heartfelt gratitude to the esteemed speakers from across the country who have kindly agreed to share their knowledge and experience with us. I encourage all participants to attend every session with discipline and active involvement. Please interact, ask questions, and make the most of this opportunity. With these words, I officially inaugurate the webinar series and wish the program great success. Thank you and best wishes to all.
Thank you, respected Dean Ma'am. Now coming to the main part, that is our actual session. Respected chairperson of today's session, Dr. Pawan Kumar Godatwar sir, respected co-chairperson, Dr. Sheetal Chavan ma'am, honored faculty members, invited speakers, and dear postgraduate scholars, a very warm good afternoon to all. It is my great privilege to honor to introduce our keynote speaker for today, Dr. Hemlata Shetty. Dr. Shetty is currently serving as an assistant professor in Department of Rognidan at Sri B.M.K. Ayurveda Mahavidyalay, Kahed, Belgavi, Karnataka. She completed her post-graduation in Chhaya Evam Vikiran Vigyan and has also pursued a diploma in hospital management and certification in biostatistics. With more than 8 years of teaching experience, she has established herself as a dynamic academician and researcher. She has been invited as a subject expert by NCISM for postgraduate dynamic curriculum development, including research methodology, biostatistics, and Rognidana pathology. Her academic interest particularly lies in integrating Ayurvedic diagnostics with modern investigative tools, which makes her presence especially valuable for today's topic and for all Rognidana postgraduate learners. I'm sure today's session will be highly informative and concept clarifying for all of us. On behalf of our organizing committee, I extend a very warm welcome to you, ma'am. We are grateful to have you with us today. I now request Dr. Hemlata Shetty ma'am to kindly take over the session and enlighten us with her keynote address. Ma'am,
Hello? 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 Am I audible? Hello?
Video on kara.
yes, ma'am, you are audible.
Make your
Hello,
video
hello.
on camera.
Oh. मॅम आवाज येतोय
हो हो येतो
हो, येतोय, येतोय.
नाही इथे मला व्हिडिओचं ऑप्शन येत नाहीये
विजयजी. Wait for a minute. Yeah?
ओके ओके
This software is new, I think. That's why the technically issue.
We are appreciating everyone's patience. It is taking a bit longer due to a technical glitch. I request everyone to please stay connected.
visible ma'am
Yes, ma'am, you are visible and audible.
okay thank you so much for the wonderful introduction. Thank you so much the entire team, Dean ma'am, HOD sir, and the entire team of Rognidan Podar College for giving me this opportunity. So without losing much of the time, I would start the today's topic, fundamentals of Chhaya and Vikiran, which is as per the NCISM syllabus. I request the organizing team to share the PPT. No, I haven't.
Hello everyone. Dear students, I would like to say ki take pen and paper and take notes of what our keynote speaker is going to take a lecture, because these are very, very important points. Okay, fundamentals of Chhaya Vikiran Vigyan. This is, I think, module 26 for third semester. So please take note and please start writing in your notebook. Thank you.
Okay, I'm audible now, I guess.
Yes, ma'am, you're audible.
Who started sharing, so I just was removed from the co-host section, I guess. Anyway, I think you are sharing the PPT. It's fine. We can continue the same. So good afternoon, everyone. Let us just proceed with the topic. Can I go to the first slide, please? I had taken a pre-test in the group. I had put the pre-test questions. There were only 5. But yes, it has given a very good result. Almost 205 students have given me the answers. And good to know that around mostly 50% and above, 60% of the students have given the right answers of all the 5. So I think most of the audience here has read a bit of basics and are with me today. So really good, and really thank you for that, dear students. So starting with the just basics, just refresh. Let us refresh what are all imaging modalities available today. So the most basic one which is available is X-ray. Next comes the fluoroscopy, arthrography, discography, myelography, MRI, CT, USG, PET, DEXA, etc. There are many more. Intervention radiology has grown a very vast way. Now you can see there are 3 things which I have highlighted in blue. I have highlighted them in yellow because I would call them as outdated now, because MRI and CT have been developed to an extent that they have all taken over arthrography, discography, and myelography. These are not much done in today's scenarios or in today's patient care. Okay, so moving on next, first line of investigation in imaging or any patient, if you want to go for imaging, the first thing which comes to in your mind is always an X-ray. X-ray is called as the basic X-ray or the first line of imaging modality, which is opted, especially in your musculoskeletal, in your respiratory, even in your abdomen. So next slide, please.
Excuse me, ma'am, can I interrupt you, please?
Sure.
मैम एक्चुअली आपका आवाज है ना थोड़ा सा पिच हाई लो हो रहा है, तो कैन यू प्लीज मेंटेन इट?
Sure.
Yes, thank you.
Is it okay now?
Yes, okay.
Yes. I'll keep it a little closer so that doesn't happen. So should I think I have just, these are the modalities which are present in imaging, and most of them are used routine. Is it fine now?
Yes, ma'am, it is fine.
The next PPT, next slide, please. Okay. So coming to the X-ray, X-ray was invented by William Conrad Rognidan in 1985. So imagine the first X-ray which was taken and invented was somewhere around 1985. And decades later, we have evolved in imaging science to a level where everything is being replaced. Even the treatment aspect is being replaced by intervention radiology today. So other than major surgeries, even the minor most surgeries also are being taken care by intervention radiologists. So this is how the entire imaging thing has developed to date. So X-rays, as I told, it is the primary evaluation. It is not outdated. If anyone says X-ray has no use now, it's a wrong note. X-ray is always, X-ray will be always the first and primary line of imaging modality, which should be used specifically evaluating certain areas of conditions. Hello? It's fine now, na?
शाइन तो है, बट फिर भी थोड़ा पिच कम ज्यादा हो रहा है, सो दैट इम्पैक्ट थोड़ा सा कुछ आपका है तो देख लीजिए आप थोड़ा सा एडजस्ट करके. मतलब कम ज्यादा ऐसा हो रहा है, बाकी कुछ नहीं है, एवरीथिंग इज ओके, बट जस्ट ओके.
I have kept everything loud only, ma'am, from my side. Okay.
ठीक है.
Okay. As it is stated, X-ray provides an excellent contrast to fat, muscle, and bone. Where to apply which imaging modality is all important, and it has to go logically. As I told, X-ray is going to be the first line of investigation, specifically coming when you want to rule out any abnormality of bone. And if you want to differentiate bone and soft tissue, our soft tissue differentiation, then X-ray won't be a modality. So if you want to understand, if you want to know any pathologies related to bones, you are supposed to go for X-ray for sure. So X-ray would be can be only evaluation if you want to identify any bone related pathologies, right? So what are the basic concepts in X-ray which you need to know? When we come to X-ray, or imaging, we talk a lot about densities. In different modalities, there are different densities which you are supposed to know. As the basic or the fundamental, you should know the different densities, what are the terms, and how are you going to identify them on these imaging modalities. In X-ray, the densities which we speak about are two, that is radiolucent and radio-opaque. Can you take the next slide, please? Move to the next slide. Next slide. This is just an image of X-ray unit which is with us. That earlier one was the rudimentary. This one is the conventional, which is digital one. So the basics of the last one. Before slide, please. Yeah. So basic physics. As I told you, we speak about densities. Imaging is all about densities. In X-ray, we speak about two important densities. One is radio-opaque and another one is radiolucent. So X-ray, as see, entire imaging is in black and white, except the Doppler part and the echo part. The rest of the things are all black and white. So every image is going to be in black and white and different shades of gray. Same thing applies for the X-ray also. X-ray, you will be having white, black, and in between various shades of gray. So here there are two important aspects: bright, that is white color, which is going to be radio-opaque; the dark, which is dark black color, which is going to be radiolucent. So there are two important densities, radio-opaque, and second one is radiolucent. Rest of all is shades of gray. So radio-opaque are those which appear bright, white on X-rays. So all those body tissues which are going to absorb the X-rays are going to appear white. Which do not absorb and X-rays can easily pass through them are going to be dark. So bones, the best example for radio-opaque, which appears white. It is very easy for you to remember because every one of you have seen an X-ray of bone, one or the other bone. So you know bone appears white. What does that mean? Bone is white, that is radio-opaque. Now why this bone is white? Because it has calcium and it easily absorbs the X-ray radiations. And that is why it appears white. Rest of the tissues, the soft tissues surrounding the bones appear gray shades, right? Similarly, coming to the lung, next, can we just move the next slide? See, here is an example. I've given you the X-ray. The brightest one you can see in this X-ray is the metal. Metal is going to appear most bright, white in color on X-ray. Next, you can see, next to bright structure on this X-ray is the bone, your knee, your femur, and your tibia and fibula. You can see the bones are comparatively brighter to the other tissues surrounding. And next, besides the bone, you're having the soft tissues. Can you see? These are comparatively lighter to that of the bone and metal. So these are the shades of gray, right? So this is how you're going to assess X-rays, X-ray densities. Metal is bright, which is radio-opaque. Bone is bright, which is again radio-opaque. And soft tissues are shades of gray, which absorb little bit, they absorb, little bit they allow to transmit. So that is why they come in different shades of gray. So soft tissues on X-ray have shades of gray, bone has white, and metal has white. Now coming to the next slide, please. Okay. So as I told you, easy way to remember this is BPL. This is very simple mnemonic. Black passes lucent. Black, which is black on X-ray. X-ray passes through them, and that is called as radiolucent. So you remember this. Opposite to this is the white one. White, which anything white is white on X-ray, it is obstructing, or it is absorbing, or it is attenuating. These are the terms which are used in reporting, X-ray reporting: attenuation, absorption, etc. So anything on X-ray which is white, that means the X-rays have been attenuated and it is going to appear, it is radio opaque. Clear? Next. Again, this is another X-ray. I guess you are here. There is no metal, but you can see very clear differentiation of bone and soft tissue. Though soft tissue clarity is not there, but still you can see different shades of gray in the soft tissues. But bone and soft tissues are very clearly, distinctly seen on this X-ray. Okay, so any pathologies of bone, the ideal investigation or ideal imaging would be X-ray. Next. Next line. Okay. So coming to the gross anatomy on X-ray, applying the basic principles of radiolucent and radio-opaque, white and bright. Bones appear white due to high density. Anything which is having high density will be appearing brighter. This is another point. Anything which absorbs will appear bright. Anything which has higher density will be appearing white. In chest, lungs appear dark. Now, why do lungs appear dark? Because of the air. There is lung has a lung parenchyma and the alveolar spaces. So there is a lot of air and lung parenchyma. That is why the lung appears black color, because X-ray easily transmit through this lung parenchyma and the air. So that is why lung appear dark on X-ray. Coming to heart is a soft tissue structure. So that's why it appears a different shade. Sowl head. You have a cardiac sowl head on an X-ray chest. So it appears gray, shade of gray. It is going to appear in gray color. Okay. Coming to the abdomen. Now abdomen is completely consists of various soft tissue organs. So there are organs in the abdomen. So most of the abdomen is going to appear in shades of gray. Yeah, sometimes you can distinctly, if you are taking a proper erect abdomen X-ray, you can distinguish the soft tissue, you can distinguish the liver, you can distinguish the spleen. If very cleanly and very appropriately penetration and X-ray has been taken, position has been taken, then you can differentiate these structures. But abdomen X-ray, it is going to appear shades of gray. And you also have many times you can see the gas patterns. There are gas patterns. You have a gastric bubble in the left hypochondric region seen. So this is gastric bubble, that is an air. So it is going to appear black. Wherever you have a gas trapped, it is going to have a dark color. Again, gas allows X-rays to pass through them. So they are going to appear dark, right? Many times intestines, large intestine, fecal matter and air, together you can sometimes see the gas patterns. That is not an abnormality. It is just a gas pattern. Until unless there is you are not suspecting an obstruction, this and a typical gas pattern like step ladder and all, it is to be considered as normal. Coming to the pelvis, except for the hip bones and the pelvis, entire pelvis bone, it is going to appear bright. The structures all within the pelvis are going to appear in different shades of gray. Okay. Now, in abdomen and pelvis, many times we go for abdomen X-ray in order to rule out gallstones and kidney stones. Yes, stones, again for applying the principle, high density. Stones are heavy, they have high density, they can easily obstruct the X-rays. So X-rays do not pass through the stones. So anything which will not allow the X-ray to pass will appear white. This is one. Second thing, calcifications. Now calcifications, any type of calcifications again will not allow X-rays, and on X-ray these calcifications also are going to appear white. Next slide, please. Let's have a hands-on exercise. I request everyone to answer me in the chat box, whatever I'm asking. Next slide, please. Next. So this is radio opaque or radiolucent? I want everyone to please answer in the chat box. It is supposed to be an interactive. I have just given a small hands-on exercise. Now this bone is radio opaque or radiolucent? White or dark? What is this appearing? I guess I'm not getting any answers. Is it visible in your chat box? I guess only one person can speak. That is the issue with this web software. I think I have only raised the hand. Meenakshi has raised the hand. I'm not getting answers in the chat box. Should we proceed then? This question was there in pre-test also. I think almost 78% students have answered it right. So they are aware of this radiolucent and radio opaque concept. Okay, now lungs. I guess you can see lungs very clearly between the ribs. The black structure is all the lungs. And what is it? It is radiolucent or radio opaque. I am not getting any answer in chat box. It's radiolucent. Are they allowed to write in the chat box, ma'am? You can just type in chat box because you're not audible. We can move to the next. This is radiolucent. I'll only answer them now. It's an hands-on for me.
Ma'am,
Huh.
am I audible?
Yeah, you're audible now, ma'am.
Yes, maximum students have answered radiolucent. We can see the question answer section here.
Okay. Actually, I was checking the chat section. I think I should have checked that. Okay, fine. I was checking the wrong section. Thank you so much. Okay, next slide. Yeah, it is radiolucent. Next one. I've already given the answer. I think the sequence went wrong. This is the abdomen. Now, as I told you, abdomen, various shades of gray. Can you see this liver on the right hypochondric area? Can you see? At least give me a thumbs up. Reactions. Can anyone give me a reaction? This on the right in the right hypochondric region. Yes, but this is a very topic specific X-ray I have found. So I'm able to very distinctly define this liver. Can you see the spleen? Can you see the spleen on the left side? Yes, very good. Now this structure between, I can see the ascending colon, then the transverse colon and the descending colon. You can see this is the fecal matter and the gas. This is the gas pattern, fecal matter. Got it? Can you see that? Yeah. Now this is normal. This is not abnormal. Okay. So this is how your abdomen is supposed to look. The pelvis, very clearly, pelvis is a bone structure. So it is very clearly visible. The structures within hollow space, you can see, it is again shades of gray. Okay. So this is how an X-ray bone, X-ray chest, and X-ray abdomen. Can you go to the previous X-ray, please? The chest. Okay. Can you see the cardiac shadow there in the center? We call it as cardiac saw head. Can you see the cardiac shadow in the center? Yeah. That's again, heart appears gray. See the rib cage? Again, bone is brighter. Bones are brighter than the lung tissues. So clear? This is how. So you can distinguish for chest, respiratory anomalies or respiratory conditions, X-ray still till date is the primary line of investigation. As it is not that X-ray doesn't show anything. It is a misconception. I think X-ray has become rudimentary, something like that. No, even for chest diseases like conditions, pneumonia, bronchitis, yes, X-ray would be the first line of imaging which you should be indicate, which is indicated in the respiratory conditions as well, right? Yes, the gold standard is obviously CT. For soft tissues, it is CT. I agree. But first line of investigation is X-ray. Next slide, please. Next slide. Okay. Now, I think X-ray, it is clear. The basics of X-ray, radiolucent, radio opaque, in what conditions you're supposed to go for X-ray. If you want to understand, if you want to know any problem, any disease, any abnormality in the bones, you're supposed to go for an X-ray, right? Especially fractures, dislocations, any bony growths, tumors, bone tumors. Yes, you're supposed to go for X-ray as an imaging technique. And for respiratory conditions also of lower respiratory where lung is involved, that in those conditions also you are the first line of investigation will be X-ray, right? And in case of abdomen, yes, till date KUB and gallstones, etc. And your gas patterns, intestinal obstructions, interceptions, etc. were all studied till the date CT evolved on X-rays only. So X-ray would be again a first line of investigation for any abdominal, intestinal, and KUB related conditions. Next, coming to the fluoroscopy. No, keep this slide, please. Coming to the fluoroscopy. Now, fluoroscopy. Now, fluoroscopy is nothing but the extension of X-ray. In fluoroscopy, what is happening? A continuous beam of X-rays are passed through the patient part and a continuous image is generated. This continuous image together gives you a video. It looks as if you are doing a videography. So fluoroscopy is nothing but continuously X-rays are passed through a part which is being imaged, and that image, fragments of image together is shown in front of you in the form of video. So it comes in the form of video. Fluoroscopy is actually extensively, even today, is used in all your orthopedic surgeries as a C-arm. What the orthopedic surgeons call a C-arm is nothing but a fluoroscope, wherein during the surgery, where is the placement of the or the reduction has come or not, whether the implant is placed where properly or not, whether nailing is done properly or not. Everything is seen on the X-ray. That is the C-arm. Nothing but the principle of fluoroscopy is applied there. Other places where fluoroscopy is applied is urological studies, uroflowmetry, right? Angiography. It has to be angiography. It is wrongly written as angioplasty. So angiography, you insert a dye and you take a continuous X-ray, and then that is it was earlier age. So this is nothing but a fluoroscopy technique or principle which is used. I have a video link. If the organizers can play this video, the entire how the fluoroscopy is done will be clearly shown. Let's kindly start from there. You need to skip that. Can you start from 2 minutes, little ahead? Take little bit ahead. Yeah, from where I have ended that video. Yeah, little bit more. Start from here. Yeah, please play. There is no sound coming, sir. This is usually done in orthopedic surgeries. I don't know why there's no sound. Barium meal X-rays, a contrast is given to drink, and then continuous X-rays are taken, and the flow of the barium through your GI tract is imaged. This is the contrast. Like barium meal, we give barium. We can insert a dye. The front is the X-ray tube, and the X-rays are emitted from that X-ray tube, and the image is constructed behind. And that image is viewed on the from the image. Analog to digital image conversions is done, and you can see the image on your screen. This is how it is done. Thank you. Can we open the PPT? Next slide, please. So just behind, a slide before. Previous slide, please. This is the OT C-arm and how the fluoroscopy is used in C-arm. This is what patient is taken on the patient table, and everything, continuous X-ray beam is sent, and image is seen on the screen. You can see the screen very well in the this picture also. So continuously we are able to see the image of whatever is being operated, that area which is approached. Some hip surgery is going on, knee surgery is going on. That entire surgery is viewed on this image, this screen. Next. Orthography, it's again it is imaging your joints. If we want to know the joint pathologies, this was the investigation which was earlier used and very commonly used. Contrast used to be injected in the joint space, and X-ray was taken. But now this X-ray completely has been replaced with MRI and CT. So arthrography is nothing but, in today's scenario, we do contrast MRI or contrast CT, or even contrast CT MRI is not needed. Plain MRI and CT plain MRI is much better than any of the arthrography now. So MRI will give you very clear differentiation between the soft tissues, soft tissue differentiation. So ligaments, tendons, very clearly you visualize on MRI. So arthrography is no more much in existence. Arthrography video also I have put it in the PPT. I request this PPT can be shared, and students can open and entirely see how this procedure is done. It is nothing but a contrast agent is injected in the joint space, the articular space, and the joint image is taken. And based on that image, what is the problem, or where is the tear and all, it can be easily assessed. Or with how is the capsule, etc., articular surfaces also can be understood. Next slide. So arthrography is mainly used for ruling out joint pathologies. You can see here very clearly, contrast is injected and the X-ray is taken. The contrast is appearing bright. So wherever, if there is a tear, you can see very clearly the contrast will be seen between the ligaments. The ACL, PCL both are intact. There is no there is no tear here. Next. Discography, again the same principle, and a dye is injected in the disc space. the dye in the vertebral column, a dye, again, a contrast is injected with an, and then X-ray is taken, and wherever is the, what is the disc condition, based on that, based on the discography, we can clearly understand. If you want, we can show this video. This is quite clearly given. Can the organizer show this video? From where you are seeing that endo, please start from there. Yeah, please, from here. Little bit behind. You missed the start. Right from there. Whichever disc you want to remove, at that disc you have to carry out this. At that disc level, you have to carry out this procedure. This is L4, L3 disc and L5, L3. All disc spaces, they are doing this discography. You can see at those places, they insert a needle. The contrast is injected. L4, L5 disc. Now you can see L5S1. There is a disc protruded. It has come out. The nucleus pulposus has come out of the nucleus fibrosus. So you can see one. You can easily see the amount of disc or the rupture or protrusion of the disc with the discography. Thank you. Back to the slide. Similarly, it happens in even the arthrography. Next slide, please. So these are no more done because of the advanced MRI and CT. We are no more doing these procedures now. Very less. It is not done only most of the time. Now MRI has completely replaced all these graphies. The barium meal is being replaced by CT. Your discography, your arthrography, everything is replaced by MRI today. Coming to the next important, computed tomography, which is very much, it's being used a lot now, but there are terms and conditions when, until unless MRI, CT, until unless they are not indicated and not the only choice of investigation, should not be should not be done for any of the patient. Okay, this is to be kept in mind. It is not just because everything is clear on that and we go for CT. No, there are indications of CT, and if the CT is indicated in those conditions, then only a person or a patient has to undergo a CT. Otherwise, you are not allowed to unnecessarily expose any patient to CT and MRI. It is not just that they are costly. Secondly, they are also involving lot of trouble. CT is having the highest radiation dose which you will be exposing your patient to. So very carefully you are supposed to indicate. Secondly, MRI takes a very long time and there's a lot of sound issues. So again, indicate if you are asking any of the patient to undergo any of these two investigations, you need to follow the ACR guidelines. If it is indicated, then only you are supposed to ask the patient to undergo. Okay, so coming to computed tomography, very simple. What is the principle of computed tomography? Computed tomography, best example I would give, how I make my students understand is, you have a bread. You have an entire loaf of bread. You are seeing it as a whole. In CT, what we are doing, we are just cutting that loaf into pieces, and when you can take one piece and you can see the bread, that piece properly. And when you place all these pieces together, again, you are seeing the structure as one. Same thing is what is happening in computed tomography. X-rays are pushed, or X-rays are given on that area, whichever has to be imaged from all the directions. So you are invariably cutting a fragment which you want to see into various projections. So you make them into pieces, so you are able to see the individual spaces, and together you see as a one part. So in computed tomography, it is sectional, it produces sectional images of a structure. Imagine if you want to go do a CT liver. So CT liver, what is happening? The liver is sliced into different image. So every slice you are able to see on CT. That is because the X-rays are emitted in such a way they are projected from all the directions on that structure, and you are able to reconstruct an entire image or entire tissue from the slice of the tissue. Like I can reconstruct the entire image of liver with small images of the liver. Okay. Now you will, once you see next, can you just move the next slide, please? This is again Hounsfield. Can you? I have an image of CT scanner. Can you move ahead, please? Can we reach that image? Next slide. Next slide. Next. 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 I think I kept that image last. Next. Yes, this one. Previous slide, please. Yeah. So now you can see this is a CT scan in front of you. You are gantry, right? In that gantry, there is X-ray tube and a detector. Can you take the previous slide, please? Previous one. Yeah. Previous one. This one. Can you see this? There is an X-ray tube and a detector plate. This X-ray tube rotates. It rotates throughout the area which is being imaged. So continuously X-rays are projected towards the area which has to be imaged, and slice. Every projection gives you an image. This, from all the projections, you're going to get the image, and at the end a total that entire structure is reconstructed. This is what happens in CT. So X-ray tube revolves around the structure which has to be imaged, and at every seconds it is going to take image. And these images are nothing but the slices which you see on a CT image. I guess everyone has seen that CT film. You can see many images. Those images are nothing but different projections at which the X-rays have been passed through that structure. At one projection, one image is taken. Second projection, second image. Third projection, third image. So like that, all projections together gives you one simple structure. Simple example, as I gave you, the bread. Entire bread will look as one whole. I can reconstruct this bread if I even put all the slices. If I put the slices together, and then also I can reconstruct the entire loaf of bread. Same thing is applied here. This is the most simple way of explaining a CT principle, though it's a complex one. Hope you have understood the principle. Next, previous slides, please. Coming to the densities. Previous. Okay, this one. Now, basic physics with respect to densities is in X-ray, we see about the tissue densities. Major are two, the air and the bone. In case of CT, what happens? Exact densities of the tissues are measured. Like, what is the density of a soft tissue? What is the density of a bone? What is the density of a air? What is the density of fat? Everything has been given a value, and that value has been given in terms of Hounsfield units, right? So here, air has a Hounsfield unit of -1000, and bone has a Hounsfield unit of more than 1000. That is plus 1000. It is somewhere about 700 to 3000. Okay, so -1000 is air, and plus 1000 if we will take bone. In between them, there are these densities. Now, on CT, we measure the Hounsfield. On an image, when we get the image, we measure the Hounsfield units on the X-ray, CT, and we decide what is that structure. If the Hounsfield is found to be minus 1000, it is air. If the Hounsfield, if I measure the Hounsfield on the image, if it is found to be somewhere around 60 or 70 or 80, it is somewhere around blood. I will call it as blood, right? If water has a Hounsfield of 0, if I measure and I find Hounsfield as 0, it is water. It should be considered as water. So every tissue density has been calculated on CT, and we call it as in terms of Hounsfield. Okay. So what the points to be remembered here? The air has minus 1000 Hounsfield density. Bone has plus 1000 Hounsfield units, and water is 0 Hounsfield unit. These are the major reference points you should remember. Okay. Next slide, please. Next slide. So these are again blood and this. Now coming in CT, we use terms as hyperdense and hypodense and isodense. These are the three terms in the CT scan. Like in X-ray, we use radio opaque and radiolucent. On CT, we use hyperdense, hypodense, and isodense. Now, hyperdense areas on CT means bright areas, which appear white in color, which has higher attenuation. As I told you, attenuation means absorption or block. One which absorbs more are hyperdense and are going to appear white. So hyperdense, bright, higher attenuation, greater density. So one who is having more density, they will be appearing white and will be hyperdense. See, CT is nothing but extension of X-ray. So the principle is going to be same in the CT also. More dense, white color. Only name what we are giving is hyperdense. So bright, we call it as hyperdense. If it is dark, we call it as hypodense. Now, hyperdense and hypodense in CT is told with respect to the surrounding structure. Okay, whether the structure is hyperdense or hypodense or isodense is in reference to the normal structure of that image. Okay, so hyperdense means bright and hypodense means dark. Okay, hyperdense means high density. Hypodense means low density. Isodense means similar density to that of this surrounding structure. Is it clear? Moving on next slide, please. So higher Hounsfield unit, hyperdense. Now I am adding a next point here, Hounsfield unit. If my Hounsfield unit is high, it is hyperdense. It is going to appear white. So my plus 1000, which is for bone, it is going to appear bright. It is hyperdense. Now lower Hounsfield unit, that is negative Hounsfield unit, which is for air, minus 1000. I will call it as hypodense, and it is going to appear dark. Clear? Hyperdense appears bright, high density, higher Hounsfield units. Low Hounsfield unit, hypodense, appears darker and has low density. All low density structures will have lower Hounsfield units, will appear dark on CT, and will be, what will be the term used? Hypodense. Clear? Hope it is clear now. Next slide, please. Now let's have an hands-on practice. Can you tell me what is the structure? It is, now I told you hyperdense, hypodense, and isodense. This has to be told only with respect to the surrounding tissue. Now this is a brain CT. I guess you can clearly distinguish this. You can see the ventricles very clearly in this, and the cortex, brain cortex. Now the arrow which is shown, can you tell me what it is? It is hypodense, hyperdense, or isodense? I request you to write the answers, please. Is it hyperdense or hypodense or isodense? Is it similar to the structures besides it? I'm not getting answers. Am I getting answers? I guess yes. Yeah, I have to scroll down. Very good, very good. Hyperdense. Most of the answers are hyperdense. Very right. Now, this is with respect to a term. Now, can you tell me what is the density of the structure which is hyperdense here? It is higher density or lower density? Okay, what is the Hounsfield unit you are expecting here? It will be more than the structures surrounding it? Okay, plus 1,000. I don't know. I think Swati, you have written plus 1,000, beta. See, plus 1,000. Whenever there's many things, components in CT, I am comparing with the structure besides this hyperdense entity, right? So besides this hyperdense, there is this brain tissue. What is the brain tissue Hounsfield, which I have told in the earlier slide? Can you take the please previous slide? Can you take the previous? Yes, yes. Thank you. Can you see the gray matter I have given somewhere as 20 to 40 Hounsfield, white matter as 20 to 35 Hounsfield. So the one which in the image is hyperdense is greater than this 35 Hounsfield. Okay. This should be the understanding, not plus 1,000. Hyperdense, hypodense, and isodense, as I told you, it is with respect to the surrounding structure. In that image, it is the brain, it is the brain slice, right? So at the ventricle, fourth ventricle level. So at that level, I'm able to see the cortex, that is the gray and white matter. So gray and white matter, it is having an Hounsfield unit of 20 to 40. So the hyperdense is brighter compared to this density, high Hounsfield. It is probably the bleed, right? So bleed, acute bleed, that bleed Hounsfield is somewhere around 55 to 75. Got it? This is how you have to apply the concept of hyperdense, hypodense, and isodense, right? Every CT scan, it is quite complicated. It is not very easy to apply these principles. In that example, it is a brain CT, and brain CT, that hyperdense structure compared to surrounding structure is brighter, which means, and if I put my cursor and I ask for the Hounsfield unit, it will give me somewhere around 70 or 80. If I get a Hounsfield unit of 70 and 80 in a brain CT, what I should suspect would be a bleed. Okay, this is how I have to apply this concept. Okay, anyway, if it is 50% of this is clear, I would accept. Anyway, those have written higher, more, good, very nice. I guess the thing is, Devendra has also written 1,000. Someone has Sridevi 100. Very good. Bhumika 20 to 40 will not be accepted because you can see the brain, gray matter and white matter itself is somewhere around 40. And the density is brighter than the gray, the surrounding gray and white matter. So it has to be more than 40. Is it clear? I guess it is clear. Okay, chalo, good. Next slide, please. We'll go. The previous one, can you show the previous one, the blood one? I missed that slide, thinking it would confuse you people. So you can see unclotted blood has this. So I am actually, no, this is not very, like I can see and CT and tell this is unclotted. I many times have to use the Hounsfield. I see what is the Hounsfield of that density also. And then I confirm whether it is acute blood, clot blood, chronic hemorrhage, etc. Okay. Hope that is clear. Next slide, please. The hands-on. The hands-on. Next. Yeah. Next slide. This is clear. Okay. Now the arrow is wrongly placed. The one. Now this is hyperdense, hypodense, or isodense. Not that one structure, on the right. If you can just take your cursor to the right, little bit, the darker area. The darker area on there, where the cursor has come, you know. Now please tell me whether it is hyperdense, hypodense. Can you tell it is isodense? Is it isodense? Very good. Hypodense. Very good. Very good. Can you tell me the Hounsfield unit? Can you guess the Hounsfield unit? Obviously, it is going to be less than 25, right? We have seen the gray matter and white matter. Isodense. I don't know why someone has written isodense. Hamsa. It is not iso. Don't see the arrow, the darker one on the image. It is not isodense. Isodense is the next image. This is not isodense. It is darker compared to the surrounding tissues, right? The surrounding is gray and white matter. It's your brain cortex at the fourth ventricle level. This lies at the fourth ventricle level. Okay, you can see the skull. You can see the bone. The brightest one, the bone, the skull bone. This is plus 1,000, more than 1,000 Hounsfield. Hope it is very clearly visible. Then there is a skin, overlying skin also visible. Can you see the bone? The brightest structure on this image is your bone, the skull bone, which is the hyperdense. The one which is the pathological one, arrow ka tail jahan par hai, that is hypodense, and it is probably less than. Gopika has written 40. No, beta, it is not 40. It has to be less than your gray. Very good. 10 to 20 accepted, can be accepted. It is not accurate, but can be accepted. 30 likha hai, 30 Rutuja, no, 30 cannot be taken. It has to be less than your gray and this one. Okay. Anyway, main thing is whether the hypodense and isodense concept is clear to you. Can we take the next slide, please? Yes. Now you can see here, any issue, it is isodense. It is having similar density to the structure surrounding it. Is there any difference in the structure? No. So this is an isodense. Okay. So it has similar density compared to the surrounding structure. Very good. I hope isodense, hyperdense, and hypodense is very clear. Next. Okay. There is a very important concept of windowing which comes in CT, and it is really important. Now, you have to understand this windowing and then apply the concept of hyperdense, isodense, and your hyperdense. Okay. Now, what is windowing? Windowing is to manipulate a grayscale range, right? Can we take the previous PPT, please? The previous slide. I want the brain. Yeah. Now, you see here, the most of the brain is in the shades of gray, right? If I take the chest, it will be in the shades of, it will be dark and gray. If I take abdomen, again, shades of gray. Now, in case of brain, you see, though I can differentiate the gray and white matter, but it is not very distinctly visible. If I want to distinctly make this shades of gray visible, I will apply something called as windowing. I'll apply a window. I have something called as brain window. Now, this brain window will give me differentiation in the brain tissue. Like I will get, now here I'm getting only 2 or 3 shades of gray. When I apply a brain window, I will get nearly 9 to 10 shades of gray. So I can differentiate the structures similar in with respect to the shades of gray. Now in brain, I'll be applying a brain window. When I apply a brain window, that Hounsfield which I have fixed, no, that itself is stretched. Now when I stretch, what is going to happen? I am going to differentiate the shades of gray. The shades of gray are very distinctly visible now. So this is why I apply windowing. I have something as brain window, then I have something as soft tissue window, right? So I apply these windows and I will increase the contrast. There's one more word which I will be using is contrast. So I can increase the contrast. You use this contrast in your TV and all. No, you increase the contrast. You see very dark light. Similar concept is of the windowing. So I will be able to differentiate the structures on a better way by applying the window. Okay, next slide, please. Okay, windowing is nothing but manipulating the grayscale based on Hounsfield unit. So here I'll not deal with window width and window level. This is very complicated. So simple thing, if I want to tell you, it is optimizing the image contrast and brightness for better visualization of soft tissues. Clear? I am just adjusting the brightness, I am adjusting the contrast, and I am visualizing the structures very clearly. This is what I do when I apply the window. The standard brain window uses width of 70 to 100 Hounsfield, right? And width and level, these are two concepts, and level around 30 to 40 Hounsfield, right? So when I apply this window, I will be able to distinctly differentiate the brain tissues. Is it clear? It is like increasing the contrast and brightness in the simple way. Next slide, please. I'll have an example to show. Very good. Now, can you see this? One side, I have a brain window where I have set an Hounsfield of 80 to 25. The right side, can you see the one image? And the other side, it is 200 to 62. Is it clear? Now, when I have increased, see, windowing is very important. See, on the 80 to 25 window, I am not able to distinctly find out the hematoma. There is a hematoma and which I can easily see it on 200 to 62 Hounsfield window, brain window. Can you see that? The arrows are pointing out. It is very different. It is different from the brain, what you call density and the skull. It is between skull and brain tissue. You are seeing a different shade of gray, right? That I am able to differentiate by applying the window. If I apply the window, it is more clearly. Here in 80 to 25, that hematoma is blending with the skull. I'm not able to differentiate. This is what is importance of windowing. Anyway, when as the CT classes proceed, we will have a separate CT. That time, this all will be very clearly. This is just a basic. You should know the densities. You should know the windowing. When it comes to the CT scan. I hope it is clear. If not clear, at least 50% of you have understood what it is. Next slide, please. This is what I have told you. There is the CT. I'll give this PPT. You can open. You can see the video how a CT scan works. As I told you, this is the X-ray tube. This is the detector, and this X-ray tube rotates around in the circle, taking multiple projections, and the image is developed. Okay. Next slide, please. Okay, now coming to the magnetic resonance imaging. Magnetic resonance imaging, it's almost, you can say, a decade later, somewhere around 1973 after X-ray. So your magnetic resonance imaging has come into the picture. And this MRI is based on the principle that your body is made up of water. Most of your body is made up of water. So there is hydrogen proton. I think you need to apply a little bit of physics, understand a little bit of physics. So whenever a proton comes in the magnetic field, it aligns with the magnetic field. However it is rotating, once it comes in the magnetic field, it starts aligning in the magnetic field. And when you remove the magnetic field, it comes to its own position. This is the principle which is applied in MRI. So when it aligns with the magnetic field and when it comes back to its normal, there is exchange, or there is release of certain waves, energies in the form of waves. These waves are undertaken and image is constructed. This is the principle actually. If you understood or not, it's a simple way. Body ka hydrogen protons, if kept in magnetic field, they align. When magnetic field is removed, they go back to their normal, whatever is the rotational positions. So this alignment and going back to the normal has some exchange of energies. These energies are emitted in the form of waves. These waves are captured and images constructed. This is the principle. Hope it is understood. Okay. So now MRI, now where all you are supposed to apply this MRI? MRI, if you want to differentiate bone soft tissues, right? Mainly your soft tissues, ligaments, and neurovascular structures. You are supposed to use the MRI. Okay. To visualize bone, MRI is not an option. X-ray would be the first option. If you want to if you want to understand more like fractures and fractures related fragments, CT would be ideal and not an MRI. Yes, if I want to understand the soft tissues related to joints like tendons, ligaments, or any neurovascular brachial plexus, etc., then I'll surely go for MRI. Okay, so neurovascular and soft tissues, I will be focused. I will take the imaging as MRI. Okay, next slide, please. Okay, now in X-ray we had radioopaque, radiolucent. In CT we had hyperdense, we had hypodense, isodense. In case of MRI, we have something called as intensities: hyper intense, hypo intense. So in MRI, we speak in terms of intensity, hyper intense and hypo intense structures. Okay, so MRI measures proton density, T1, T2 relaxation time, and diffusions to differentiate the tissues. Now, this proton density, T1, T2 relaxation time, diffusion, these are all very technical terms. The simple thing I have already told: hydrogen aligns with the magnetic field, then goes to the normal. When this happens, all this relaxation time, diffusion, proton is all coming in picture. Okay, and so we have so MRI, as written here, it comes from the hydrogen protons. All those structures which have high hydrogen protons are going to appear bright. Or on PD, see, MRI is of different types. You have T1 weighted MRI, T2 MRI, you have proton density MRI, you have diffusion MRI, you have flare sequences. So these are types of MRI. So on proton density MRI, what does proton density MRI does? Proton density MRI, if you're taking a sequence, then wherever the proton density is more, those structures will appear bright. Now protons will be more wherever water related things are there. Now here I have given an example of CSF. CSF has a water content, yes. So hydrogen content, yes. So hydrogen is nothing but here proton. So wherever you have proton, high proton, those structures are going to appear bright on proton density MRIs. This is now a little confusing. I guess just be with me. Try understanding. If anything, I can just repeat it for you, but please don't get confused at this. There is, in MRI, we have proton density, T1 weighted, T2 weighted, diffusion MRIs, and etc. These are the main four. A flare sequence also. There are many sequences. I am just going to tell you about proton density and T1 and T2. I won't even include the diffusion to keep it simple. Once you understand the intensities, then you can apply this concept for understanding other sequences. Okay, in proton density MRI sequences, what happens? Those tissues which have high protons are going to appear bright. they are hyper intense, like here CSF. Fine. Those who have low proton density will appear intermediate, right? Different scales of grade. Those have very low proton density, they will appear dark. Okay? Those have high proton density, like example CSF, will appear bright. Other with less proton densities will appear intermediate, and with low proton density in the tissues will appear darker. Clear? This is about proton density sequence. Coming to T1 weighted image, T2 weighted. This is the most commonly used MRI sequence, right? Everyone uses T1 weighted, T2 weighted. So this is important for you to understand. Remember this. T1 weighted image, fat appears bright and fluid appears dark. T2 weighted image, fat appears dark and fluid appears bright. Clear? T1 fat bright, T2 fluid bright. Is it clear? Is it clear? Just give me some reactions. No, yes, thumbs up, thumbs down. Okay, I think I got 1, 2. Chalo, I understand. This is a little bit confusing. Forget about proton. Just focus on T1 weighted, T2 weighted. T1 weighted images, fat appears bright. T2 weighted images, fat appears dark. T1 weighted image, fluid appears dark. T2 images, fluid appears bright. Okay. Next, we will not discuss the diffusion one. Next slide, please. Next slide. Okay, very good. See, this is a proton PD, proton density image, and the B1 is a weighted image. Now, as I told you, mainly proton density sequence is used in order to rule out lesions, right? Soft tissue lesions, which are usually missed, you know. So proton density with fat suppression, specifically very ideal for ruling out lesions. There are indications of these sequences. We will we are dropping this proton density also. We will focus only on T1 and T2. Next slide, please. Okay. This is an, I don't know, please. This is an hands-on. I want you to tell me which one is T1 and which one is T2. The left one is T1 or T2, or the right one is T1 or T2. This is an hands-on exercise. Apply the concept which I have told you, T1 weighted and T2 weighted. You are going to answer me now in the chat box. Tell me which one is T1, which one is T2. This is MRI spine. I guess you are able to identify the structure. It is MRI spine, LS spine. I want you to kindly answer me. Okay, left. Can you tell me left side is what? Left side is T1. Right side is T2. Very good. Second is T1. This T2. Left is T1, right is T2. Okay. Most of them, if you have answered right, very good, very good. Now I guess if you're writing, you have applied the concept. Fluid appears bright on T2, right? Simple way here is what I am going to see is only the CSF. Just check for CSF. In your this LS spine MRI, you are very clearly able to see the spinal canal. Can you see the spinal canal behind this vertebral column? On the left side, this spinal canal is dark. And on the right side image, the spinal canal, you can see it is bright. Now, spinal canal, other than spinal cord, it has CSF. So CSF is fluid. On T2, your face appears bright. So just applied, I have applied this concept and I have applied this on this image. So T2 is my right side and T1 is my left side. Another way to identify here is your disc. Can you see the disc? Now, disc has two parts, right? The external fibrosis and internal pulposus, annulus pulposus. So this pulposus is a water. It is a slimy structure, right? It has water content. So you can see on the right side image, my disc center appears white, right? This is another way to identify. Hope this is very clear. Hope you are able to understand T1 and T2 and hyperdense and hyperintense and hypointense. Next slide, please. Next slide, please. These are the structures. This is how your entire MRI chamber is. See, you can see the magnet. You have something called as gradient coil. Then you have an RF coil, the patient table. This magnet, gradient coil are continuously on. RF coil, the RF radio frequency waves are intermittently sent and sequences are generated. This goes about a lot of physics. It is not the topic for today's discussion. It is just the fundamental. This is the structure of your MRI machine. Next, please. Next slide. Okay. I hope this would be the last. Coming to the USG. USG was by Carl Disick in 1942. It is on the principle of ultrasound. It is on the principle of submarine. The same principle what submarine uses. Same principle was applied by Carl Disick in the medical field. What in USG, what is the thing happening? You are emitting the sound waves. Now these sound waves will go and hit your structures. Now when any wave like radiation, X-ray went and hit your tissue, it is either absorbed or it is reflected or it is passed through. Same thing happens with the sound waves. When the sound waves enter your tissue body, they go have interface with the tissues. Now this tissue interface has a term in USG. We call it as acoustic impedance. And based on this acoustic impedance, your image is produced, right? So simple way, your sound waves enter your body, they go and hit the tissue. Either the tissue will absorb it, or it will reflect it, or it will allow to pass through, right? When it is reflecting, usually some of the amount of the sound waves are reflected back. This reflected or this echoes, when these sound waves are reflected back, these sound waves are taken and an image based on this, an image is produced, like from how much length this has come back. These echoes are coming and the density, the speed of the echo, all together an image is produced. This is all physics. Everything physics is applied and an image is produced. Remember for now. So your sound waves are pushed in your body. They go have a tissue interaction, tissue interface. They are reflected. They are reflected back. These reflected sound waves are called as echoes. These echoes are studied and image is produced. Got it? Is it clear? There are two important principles used here, piezoelectric and pulse echo. I have only spoken about pulse echo. Piezoelectric is very specific physics which applies with how the sound waves are produced. So that you need not know. Pulse echo is the principle which is responsible for image production, right? So sound waves go, hit the structure, they are reflected, echoed back. These echoes are captured and image is produced. This is the simple image, simple physics, what is applied in pulse echo in USG. Okay, next slide. This is how an USG machine looks. I guess everyone has seen this machine. These are the transducer. Transducers are the one which produce the sound waves. From the transducer, sound waves are produced. Sound waves travel within your body and then they hit the tissues. From the tissues,
They are reflected back as echoes. These echoes are taken back by the transducers only, and from transducer, these signals are transferred to the camera, this monitor, the developing processing unit. The processing unit produces the image. This is how it is happening in everywhere. Your digital X-ray, CT, MRI, and your USG also. Okay, the waves are captured and the image is produced. In MRI, the proton, the whatever energy differences is there, that is captured and image is produced. Okay, next slide, please. Okay, coming to the densities with respect to USG. See how sound waves bounce back from the tissue based on acoustic impedance. The densities have been defined. So here densities are anechoic, hypoechoic, isoechoic, and hyperechoic. Anechoic means no echo. There is no echo. The tissue has not reflected, so echo has not come back. So those anechoic densities will appear black color. And which are these tissues? The fluid. Fluid in your body is anechoic, which is going to appear black. Remember, anechoic, fluid, black. Okay, hypoechoic. Now, hypoechoic are those which have produced less, which are reflecting less echoes. They are going to appear shades of gray. Which are these? Muscles, liver, spleen, etc. Isoechoic, same as nearby structures. These are your testes, your thyroid, etc. And hyperechoic, which immediately reflects back. So, which appear bright. That is fat, bone, gallstones, right? And there is something called as acoustic shadow or posterior shadowing, which is very well seen in stones, stone and gas. Okay, we'll remove the shadowing part. Remember the four densities: anechoic, hypoechoic, isoechoic, and hyperechoic, right? Anechoic, black, there is no echo. Hypoechoic, shade of gray, there is mild echoing. Isoechoic, that is having similar echo with the surrounding structures. And hyper echo, which is maximum echoes, that is maximum sound waves are reflected back, and these are going to appear bright. Is it clear? Is it clear? I think everyone, it's almost. Anyway, assuming it to be clear. Next, please. Next slide, please. For today's understanding, focus only on this part. If you're not understanding iso, hypo and all, simple. Fluid anechoic appears black on USG. Soft tissue hypoechoic appears shades of gray. And bone hyperechoic appears bright. Is this clear now? This is the simplest thing which you can take home today. Okay? Next slide, please. Can you see this? The different shades of gray. The muscle fiber is appearing darker, fascia, subcutaneous tissue, and skin. This is how USG of, I think this is probably some muscle tissue. So this is how your structures, if I'm doing my shoulder also, I would be seeing something like this. You on USG. Okay. I think this will be the last. There's no more slide. This is the last one, I guess, sir. Can you see the next one? I think this is the last. Yes. Okay. Hope the densities are very clear. X-ray densities, CT density, MRI density, and USG densities. Okay, here I end my today's lecture. Hope it was clear, and if there are any doubts, any questions, students can ask. Thank you so much.
Thank you so much, ma'am. I request students, if there's any doubt, you can ask in question answer session. Okay, you have to raise your hands. Raise a hand if there's a doubt. So you can check the question answer session for attendance form. You have to fill up the attendance form and submit.
Someone wants to see the second last slide. Can you just please show them? This is just a brush up because in future classes I'll be using these terms. So I don't want you people to, that time get confused what these terms mean.
May I disturb you, Hemlata madam?
Yes, ma'am.
A very good interactive session, madam. So, dear students, I just wanted to know you that everything, the fundamentals of Chhaya Vikiran Vigyan radiology, madam has elaborated. So, if you have any doubts, you can ask her right now, because in the next session, we are going to learn about practical training as well as experiential learning. If you have any doubts, ask right now. Otherwise, the experiential learning, you cannot proceed. So madam is going to give you the exercises for experiential learning. So please ask if any doubts. Hemlata madam.
Yes.
Madam.
Yes, ma'am.
Regarding practical training, are you going to give some instructions to our students?
Yes, ma'am. I request.
Please go for that for 2 minutes only. Huh?
Now, since I've already explained about the densities, ma'am,
Yeah.
There must be some X-ray unit or some imaging radiology unit in your institutes.
Ma'am, I think you just allowed them in the group what experiential learning they have to work on that.
Ma'am,
Okay.
Experiential, I'll give in a proper write-up way.
Yes, definitely. Thank you.
I don't know from which college how many are there.
Yeah.
I'll just give a group-wise activity. But for
Yes.
practical is what, now whatever densities they have understood, I just want them to go and understand, see them in life. Like they have to go to the X-ray unit, they have to take X-rays, they have to just see the structures which are appearing bright, which are appearing dark. I want them to take MRIs from there, wherever in the institute or wherever they are able to, or online.
Means this is about all.
Teachers can provide them.
Yeah. This is all about practical training, right?
Yeah. I want them to hold them and just see which structures are bright.
Yeah.
And note them. I want them
Yes.
to note on X-ray which all structures, if they have taken a knee X-ray in their hand and they're visualizing, I want them to say which structure on that knee X-ray appears to be bright, which appears to be shades of gray, which all has appeared to be. Can they identify these structures with respect to these densities? X-ray is very easy, ma'am. Coming to MRI and CT, USG, though I don't think it will be possible. But CT and MRI, it is possible. They can take X-ray, CT, MRI, and see which pictures on CT and MRI appear bright, which are appearing dark. So this is what I want.
Okay, means practical training is, so all dear student, please note that practical training is nothing but what madam has taught you today, that is fundamentals in radiology. You have to learn that things from book as well as hear this recorded PPT once again, and then go for practicals, means go in the X-ray room, go in learn the X-rays, then how to काय त्या density वगैरे जे काही सांगितलं मॅडमनी, learn on that, as well as learn from the books, read from the books. So this is about go to the wards as well. So this is nothing but the practical training, right madam?
Yes, wherever you are able to find the imaging,
Yes,
imaging.
dear student, I hope now you all will understood what is practical training about the fundamentals of Chhaya Vikiran Vigyan. So madam will post on groups about experiential learning, right, madam?
Yes, ma'am.
Yes. Okay, fine. Very good.
Okay, I hope we have covered all the questions or doubts of the students. We'll move ahead now with our session. Now I invite our respected co-chairperson, Dr. Sheetal Chavan ma'am. Dr. Sheetal is an associate professor in Department of Rognidan at Ayurved Seva Sangha Ayurved Mahavidyalaya, Nashik. She has published numerous research papers and has received several national awards, including Best Teacher and Best Researcher recognitions. We are honored to have such an experienced academician and researcher as a co-chairperson for today's session. I request her to kindly share her remarks regarding today's session. Ma'am,
I think you need to make her as co-host. I can remove me from co-host.
Oh, hello, I am audible now.
yes, ma'am, you're audible now.
Okay. Thank you, Renuka. Respected Dean of Podar Medical College, Mumbai, Dr. Sampada Sant ma'am, Honorable Speaker, Dr. Hemlata Shette ma'am, Chairperson, Dr. Pawan Kumar Godatwar sir, Shuri and Chairman, Dr. Santosh Tirbide sir, Organizing Secretary and Concept Developer, Dr. Jyoti Megdambar ma'am, and Coordinator, Dr. Renuka Sawant ma'am, and all faculty members and dear participants. A very good afternoon to everyone. I would like to express my immense gratitude for having me as a co-chair for the today's session, Fundamental of the Chhaya Evam Vigyan. Thank you so much, Dr. Hemlata ma'am, for delivering such an informative lecture. She gave us beautiful sight to facilitate thorough assessment to diagnose a disease. Thank you, ma'am. Understanding the Chhaya Vikiran Vigyan, that is the radiology forms and the essential bridge between the Ayurvedic diagnostic principles and the modern imaging science. In the present clinical practice, knowledge of the radiological investigation is a mandatory for accurate diagnosis, correlation, and the better patient treatment. I am confident that the today's lecture will help the all postgraduate scholars develop clarity regarding the basics of the imaging modalities and their clinical application in day-to-day practices. At last, I would like to end my words with the hope such a session would be organized in the future as well that the beneficial are both students as well as the all faculty members. Thank you and wish you session a very successful and I think discussion. Thank you very much.
Sheetal ma'am, for your thoughtful reflections and academic guidance to our students. Now I take this proud privilege to introduce the chairperson for today's session, Dr. Pawan Kumar Godatwar sir. He is presently serving as Technical Officer in Traditional Medicine at World Health Organization and is also professor in Department of Rognidan at National Institute of Ayurveda, Jaipur. We are truly honored to have such an eminent personality chairing today's session. I now humbly request our respected chairperson, Vaidya Pawan Kumar sir, to kindly deliver his opening remarks and guide the session.
Himaji, it was good to see you and hear your most erudite
Namaste, sir. Thank you so much, sir.
lecture. it was a beautiful start. I hope everyone enjoyed that. Santosh sir, Jyoti madam, congratulations to your initiatives. And I hope this learning start will go a very long in, especially in this field, which is very much untouched in our specialty. It's very needed, but not many resources are there, especially to explain it in very simple terms, explain and interpreting it in from Ayurvedic point of view. It is very important that we learn the basics from the right person who has done the PG in radiology. So I think there are only a handful, one or two outliers in our field. So Jyoti madam has very richly requested Hema madam, and Hema madam has, as expected, she has delivered a beautiful starting lecture, right? And we are waiting for the 5-course meal. So best wishes to all the participants, and I hope all the registered participants who have crossed 1,000 will actually join and listen to this what we call Gyana Yagya, what Emma madam has started so efficiently. Thanks a lot. So it will not take too much time. Already it is saturated by the density and opacities given by madam. So thanks a lot.
Thank you, sir. Thank you so much.
Over to you, Jyoti madam.
Yes, thank you, sir. Thank you, both of you, for being a chair and co-chair for our first lecture. I think this is a history, we can say, that in the Department of Rognidan, Vikriti Vigyan, from Podar Medical College, I really can say that this is the historical event. Yes, sir? Pawan Kumar, sir? Hello? Yes, sir. Pawan Kumar, sir.
Madam, respects to Dr. Sampada Sant also.
Yeah. I will convey your gratitude.
So it is
Yes,
a bit
yes,
easy and difficult, and I'm connected through mobile,
yes.
and therefore some lapses are there.
Yeah.
Pardon me, Sampada madam, namaste.
Yes, sir. I will convey your gratitude to her, sir. So once again, thank you, dear Hemlata madam. You have given a very wonderful lecture, very informative session, and very, very basic ideas you have cleared. Even for us faculties also, it is like a reorientation. Yes, sir. मला वाटतं की सगळ्यांसाठीचे खूप आमच्यासाठी सुद्धा फॅकल्टीसाठी this is like reorientation and very basic ideas you have cleared. And even what about practical training and experiential learning? There are so many confusions. Okay, so this confusion, I think now it is very much mirror cleared to this third semester batch, right, Rutuja, Ruhat and Shubham? So once again, thank you very much, madam. Now over to my HOD, Dr. Santosh Girbide, sir. Sir, काय सर तुम्हाला बोलायचं काय, संदीप सर बोलता सर? थँक्यू वगैरे. Vote of thanks.
Okay. So now to express gratitude on behalf of all the students, I welcome my student, our PG student, Dr. Rutuja Chavan, to deliver the vote of thanks.
Good afternoon, everyone. Honorable Speaker, respected teachers, and dear participants, on behalf of the Department of Rognidan, Evam Vikriti Vigyan, I feel privileged to propose the vote of thanks for today's enlightening session of the Ayrn PG Academic Forum 2026. First and foremost, I express our heartfelt gratitude to our esteemed speaker, Dr. Hemlata ma'am, for sharing such valuable knowledge and practical insights with us. Your lecture has greatly enhanced our understanding and will definitely guide us in both academic learning and clinical practices. You have really well described all the concepts to us, and it has been very clear for us. The arthrography, discography, fluoroscopy, CT, their different densities, USG and the different densities are very well cleared. First, ma'am, thank you so much for that. I sincerely thank our respected Dean ma'am for her constant encouragement, support, and for motivating us to conduct academic activities that enrich postgraduate education. I also extend my gratitude to all the faculty members and coordinators of the guidance for their guidance and continuous support in organizing the webinar successfully. A special thanks to the organizing team and IT team for their dedicated efforts behind the scenes in managing the technical aspects and ensuring the smooth conduct of the session. Lastly, I thank all the participants for their active involvement and interaction, which truly made this session meaningful and successful. Thank you, everyone.
Thank you, Rutuja, for a beautiful vote of thanks. With this, we come to the end of today's academic session. We sincerely thank our chairperson, co-chairperson, keynote speaker, Dr. Hemlata Shete ma'am, faculty members, and all participants for their gracious presence and active participation. We look forward to your participation in our upcoming sessions. Thank you all. Have a wonderful evening. Okay, next session. Our next session will be on Wednesday regarding hematology. All the preparations you have to do for the session will be declared on the group of our webinar. Thank you.
Thank you.